Bismillah ar-Rahman ar-Rahim. Welcome in this new CMA meeting of Egyptian Society of Nephrology and Transplantation. In usual time, our usual time weekly meeting, Wednesday, 9 p.m. Today, we are honored to have our great speaker, Professor Riyad Saied, and our great moderator, Professor Maya Hasaballah. Professor Maya is the professor of nephrology and internal medicine at Cairo University. She is the current president of Egyptian Society of Nephrology and Transplantation, and the current MISAT General Secretary. We are honored to have Professor Riyad Saied as our speaker, speaking about one of the hot topics, which is hyperuricemia, one of the very conflicting topic and in CKD and dialysis. Professor Riyad is well known for us, and he is a professor of nephrology and in medicine in Jordan University Hospital, past president of many societies, international and national societies. And I will leave the floor for Professor Mai to introduce Professor Riyad in details to recover our old days of Egyptian Society of Nephrology and Transplantation and Arab Society of Nephrology. Welcome for all our attendees, all our attending professors, and all our attending colleagues. And welcome, Professor Mai, welcome, Professor Riyad, in this very interesting session. Please, Professor Mai.
Thank you very much, Professor Yasser. And it's really an honor and a privilege. And we are all very lucky to have Professor Riyad Saied with us today. And we always learn from him over many years. Of course, you all know Professor Riyad, but just I would like to, for those who might not know him, he graduated from Cairo University Medical School in 1968, and he got his training of internal medicine and nephrology in Northwestern University in Chicago, USA. American Board of Internal Medicine, 1976, and American Board of Nephrology, 1978, a fellow in the American Society of Nephrology. And of course, he's a professor of medicine and nephrology, Jordan University Medical School, 1997. He is the past chairman of ISN Comgan Middle East region and the ISN council member for Middle East 2005-2011. And he is a recipient of ISN Pioneer Award Middle East region 2017. He is the past president of the Jordanian Society of Nephrology 2002-2006, and the past president of the Arab Society of Nephrology and Renal Transplantation from 2000 to 2002. And he is the director of medical education and training in Jordan Hospital Amman. And above all, he is a very dear friend to us for many, many years. And we really thank you for being with us today, Professor Riyad. And he will be talking on a very hot topic that is still rather controversial and some kind of a gray zone, hyperuricemia in CKD and kidney transplantation. Please, Dr. Riyad, go on. You unmute, Dr. Riyad, you're muted. Oh. Yes.
Okay. Thank you very much, Dr. Mai, for this introduction. Thank you, Dr. Yasser. I'd like to thank our colleagues in Egyptian Society of Nephrology Transplantation, which is really a good partner of our society in Jordan. And I hope in the coming session, I will cover the hyperuricemia in CKD and kidney transplantation that Dr. Yasser requested me to do. Okay, well, thank you again. Bismillah ar-Rahman ar-Rahim. Now, let's move. Okay, well, this is the agenda for me for today, something about physiology, understand really uric acid physiology and purine metabolism, hyperuricemia, the kidney hyperuricemia, and then urate lowering agent, and then we'll summarize what will happen at the end. Now, as you know that uric acid basically is a weak organic acid with a functional pK of approximately 5.75, and it's the end product of purine metabolism in humans and some primates. At a normal arterial pH, we know that uric acid dissociates into urate, which is the anion and hydrogen ion. This reaction usually is more tuned toward the right, so we have more urate is present, and uric acid in our body circulates mostly in the soluble form as urate anion. Normal serum urate concentration approaches the theoretical limit of solubility of urate, which is 6.8 milligram per deciliter. We know that urate is usually not ingested, but there are major sites of urate production is the liver, that produced by degradation of both dietary and endogenously synthesized purine compounds. Dietary intake appears to provide significant source of urate precursors, as we know that purine-free formula diet usually reduce excretion by almost 40% of uric acid. We know that urate production depends upon purine degradation, and this involves breakdown of purine mononucleotides, guanylic acid, which means guanosine monophosphate, inosinic acid, inosine phosphate monophosphate, adenylic acid, adenosine monophosphate. The degradation of these products ultimately result in what we call purine-based guanine and hypoxanthine. Then both guanine and hypoxanthine are metabolized to xanthine by xanthine oxidase. And the final step of this really synthesis, usually xanthine is irreversibly oxidized to urate and uric acid, which is catalyzed by the enzyme xanthine oxidase. This is really what I'm talking about. Adenosine monophosphate, inosine monophosphate, guanosine monophosphate, through certain enzymatic link will be into end product guanine and hypoxanthine. Then both guanine and hypoxanthine will be metabolized into xanthine by xanthine oxidase inhibitor, and then xanthine oxidase inhibitor will metabolize xanthine into urate and uric acid, which is the dissociated form. Most of the time we have the urate. This is in short. And the major site usually, as I mentioned, is the liver through a lot of enzymatic processes that happen, but ultimately we're going to end with uric acid that we have. Now in humans, because we are lacking the uricase enzyme that usually present in primates, which converts uric acid into allantoin, and allantoin usually is secreted in the urine of these primates. Unfortunately, in human being, we don't have this because the gene really is being pseudogene called. We accumulate urate in our body, and the only source really to get urate out of our body is the gut, 30% of our pool, and then the kidney, around 70% of that. Most of it usually being reabsorbed. Now, we know that the body pool of urate is approximately 1,200 milligram soluble urate. A typical adult male patient usually has twice that of the female, simply because of the estrogenic effect on the reabsorption. Normal human have a serum urate concentration 6.8 milligram per deciliter, regularly excrete in the urine, supersaturated with respect to uric acid. And that's why we wonder why we don't have uric acid tones, most of us. Under normal steady state condition, daily turnover, 60% of the urate pool is achieved by balance between production and elimination of urate. Urate usually in our body is not really metabolized. There is a very little metabolism of urate in our body. So we have to get rid of it through the kidney and the gut. So the disposal of uric acid depends upon 1/3 in the gut and 2/3 through the kidney. Now, in the gut, which is an active process mediated by urate transporter, best studied by the transporter of ABCG2 called. This ABG2 is highly capacity urate transporter encoded usually by gene chromosome 4. It's expressed basically on the intestinal epithelium and also in the luminal surface of proximal convoluted tubule. Once the urate is really in the gut, it has been degraded by bacteria by a process called intestinal urocolysis, and this breakdown responsible for 1/3 of our urate disposal. Now the kidney is the major site after that usually. We know that uric acid normally accounts for the remaining 2/3, usually daily uric acid disposal. Nearly all urate is readily available to filtration because it's not protein bound. Now, the renal handling of urate usually involves filtration, separate tubular reabsorptive and secretory processes mediated by completely separate sets of transport mechanism. And then the final thing is urinary excretion. Now, we know that renal clearance of uric acid in normal individual around 7 to 12% of the filtered load. That indicates the net tubular reabsorption of uric acid almost 90% of our filtered load. Now, this schema will show us that how the kidney really works. Now, we have the filtration 100% filtered of the uric acid. Most of the uric acid is being reabsorbed in the proximal convoluted tubule. Around 92, less than 2% will escape. And then we have reabsorptive site again in the proximal convoluted tubule, 50% usually secreted. And then we have post-secretory reabsorptive site. So a filtration, reabsorption, secretion, post-secretory site, and then the end result, usually secretion of uric acid, excretion of uric acid will be around 10%. And that reflected on a daily load of uric acid in a male patient, 750 milligram per day, that's in the urine. In female, around 700 milligram. It's on the average 10 milligram per kilogram body weight. It's important to remember these figures. Now, let's see how the kidney really handles this, the absorptive site. We know that this is the lumen, this is the apical part of the renal tubule, that's a basolateral, and we have the filtrate of uric acid here. Most of the urate absorption occurs in the proximal convoluted tubule. Filtered urate is reabsorbed at the apical site through enzymatic changes. We know that sodium reabsorption got with it lactate, pyruvate, nitric acid, salicylate, and pyrazinamide. These are mono anions, and then it will exchange with urate, usually through the urate transporter mechanism, and it will go into the cell. Once it's in the cell, we have the GL29, which is the main transporter that allow urate from the body, from the cell to go into the room, into the blood space. So by this, we have the absorption processes. It's an active one. It requires really energy ATP. Now, equally so, we have also secretion of uric acid. Now, this is the blood compartment, that's the lateral aspect, and that's the apical part. So urate is exchanged through the alpha-ketogluteric acid with the OT1 and OT3 transporter into the cell, and then at the apical part, it will be transferred into the lumen, secreted into the lumen through, again, ATP through different enzymatic processes. So the net result really of all these things, filtration, reabsorption, secretion, and then we have the final part of it. Now, the hyperuricemia, it happened that it is a state of balance between production and excretion. If there is an increased production, decreased secretion, so that's usually what will happen. Now, or we may have a combination of that, increased production, decreased secretion, or combination of both. They may happen, result in hyperuricemia. Can we get this here a little bit? Yes. Now, how we develop hyperuricemia? Well, basically secondary to defect in urine metabolism, which is an enzymatic deficiency. Typical example, and we have hypoxanthine guanine phosphorypurate transferase deficiency that result in Lesch-Nyhan syndrome, or the 5-PRP synthetic activity increase, or glucose 6-phosphatase deficiency, which is glycogen storage disease, that myogenic hyperuricemia. All this will result in hyperuricemia, and that's a typical example. What we have, a kid with what we call Lesch-Nyhan syndrome, where is a deficiency of the hypoxanthine guanine phosphorypurate transferase enzyme, resulting in accumulation of both hypoxanthine guanine degraded into uric acid. Excessive uric acid usually results in orange urine, severe mental retardation, self-utination, involuntary movement, and gout. So that's the excessive production of uric acid. Then we have secondary forms usually of overproduction, clinical disorder, myeloproliferative disorder, like myeloproliferative disorder, lymphoproliferative disorder, hemolysis, psoriasis, tissue hypoxia, Down syndrome, glycogen storage diseases. And again, we may have a diet or excessive intake of some materials that really rich in alcohols and others, ethanol ingestion, extensive dietary purine injection, and excessive fructose ingestion cytotoxic drugs. And I listed for you here the high purine diet, food and drinks, meat, alcohols, sweetened sugar, organ meats like liver and kidneys, seafood, and sweets, mostly high in fructose. All these really intake of these substances result in high uric acid level in our body. And then also, there is a decreased now disorder, hyperuricemia, decreased uric acid clearance, kidney disease from any form, because decreased GFR, lead nephropathy, which is Saturn gout. We don't see it here. It has been southwest of the United States, where we have the moonshine, effective volume depletion, diabetic or starvation, ketoacidosis, lactic acidosis, preeclampsia. All of us are familiar with the role of renal uric acid in preeclampsia. And then we have what we call autosomal dominant tubular interstitial disease, uromodulin kidney disorder due to uric acid being high, and then glomerulocystic kidney disease, plus a lot of other gene difficulties that we really difficult to go through all of them. I listed for you here what medication that really we deal with. Drugs that increase serum uric acid, drugs that lower serum uric acid concentration. That's quite important really for what we're going to talk about later on. We have diuretics increased, tacrolimus, cyclosporin, which is quite important for us as a nephrologist, with transplantation, ethambutol, pyrazinamide, cytotoxic agent, alcohol. Remember, salicylate in low dose will give you rise, while salicylate in high dose usually will give you low serum uric acid concentration. One of the blood pressure medication that's quite important really for us is losartan. It has the capacity of lowering uric acid, and that will come really when we talk about management. Now, what really talking about hyperuricemia now, what does really hyperuricemia to us from regardless of the etiology, diet, tissue destruction, endogenous synthesis, increase urate, whether it's overproduction or under secretion, the end result in hyperuricemia. Hyperuricemia could be asymptomatic, silent, could induce gout, renal manifestation, unassociated vascular event and mortalities. So it's really a wide spectrum. Now, what about asymptomatic hyperuricemia? Well, asymptomatic hyperuricemia is usually a term traditionally applied to setting in which urine concentration is elevated, but there are no symptoms. There is no gout, there is no uric acid stone or renal disease. A practical and clinical relevant definition, usually uric acid more than 6, usually we worry about that. Nearly the prevalence around 20 to 25% of adult men and smaller percentage of women, they have asymptomatic hyperuricemia. And about 2/3 of them will continue to have no symptoms. So that will be a big question whether need treatment or not. Now, but unfortunately, persistent urate level more than 8 is a threshold for initiating evaluation, lifestyle modification, pharmacological intervention for management of asymptomatic hyperuricemia. Asymptomatic hyperuricemia is linked to a sort of arterial hypertension, diabetes, chronic kidney disease. So we have to pay attention to that. And we know that uric acid level have been shown to be independently related to greater incidence of cardiovascular complication. How it works really? It works at the intracellular level and at the clinical level. So from hyperuricemia, stimulate the RAS, causing hypertension and all the potential complication. Stimulate chemokines, activation of the respiratory enzymes, reduction of nitrogen oxide bioavailability, vasoconstrictor mediators. So all these will result in some clinical aspect, endothelial dysfunction, coronary artery disease, CKD, hypertension, heart failure, stroke, and gout. So really, it's not a benign condition if it really persists for a longer period of time. We know that hyperuricemia with other comorbidities, emerging risk factors, atherosclerosis, hypertension, cardiovascular disease, chronic kidney disease, and stroke. What about metabolic syndrome? Look about metabolic syndrome, really. It's related to the level of serum uric acid. Serum uric 6, 6.9, 8.9, 10, up to 70%, they will develop usually metabolic syndrome. They have high uric acid. So we should be aware of the potential trouble of high uric acid in patients with metabolic syndrome and its potential treatment. We know that hyperuricemia is a risk factor for incident hypertension. Well, systemic review, almost 25 studies, more 97,000 participants. Usually, uric acid was associated with the incident hypertension. As you'll see here, hyperuricemia, all these are in favor, and few of them are not really. So it's there. And we know that an increase in serum uric acid, 1 milligram per deciliter, the prevalence of hypertension goes 1.2 folds. Compare uric acid here around 10, both systolic and diastolic, and uric acid around 2 to 3, around almost 10 folds increase in the incidence of hypertension. What about cardiovascular risk? Same thing is happening. Here, hyperuricemia, cardiovascular mortality, it has a positive correlation between serum uric acid and cardiovascular mortality. You'll see that high uric acid, and it's almost 1.4 higher risk that it can happen. And there is 15% increase in cardiovascular mortality for every 1 milligram per deciliter increase in uric acid. And reference usually uric acid is 5.5. So really, it's not a benign condition. What about stroke? Same thing, stroke may occur. Stroke incidence increased and mortality usually increased in patients with hyperuricemia. What about, as you see here, 1 milligram increase in serum uric acid, usually 13% adjusted risk of stroke. It can happen, hyperuricemia and normal uricemia. And then what happened with diabetes? Same thing, remittent hyperuricemia and incident hyperuricemia, almost 35% and 48% higher risk of developing diabetes. So all the other comorbidities that we deal with in our patients are usually increased in relevance to hyperuricemia. Now, what about kidneys? I've left this here to concentrate more about the kidney. Uric acid increased the risk of kidney disease. Look about, this is almost 18,000 patients, 110 of them CKD and the other non-CKD. Look about the GFR. Look about the uric acid. And most of them are elderly, more older age usually. They have hypertension around, and this is quite significant. So really, it has a good number of them. This is really Framingham follow-up study for almost 8.5 years. Not only that, from different studies all over the world, predicting uric acid and development of CKD. Japan, Thailand, USA, Australia, and this is the number of patients, all of them, yes, 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 yes. So most of these studies are really indicating a good predictor for kidney disease from hyperuricemia. Now, what about incidence of CKD in patients who are diabetic and preserved kidney function? Two groups of individuals, 1,000 without hyperuricemia, 159 patients with hyperuricemia. Look about GFR, 76 ml per minute plus minus. Here it's 82, which is quite significant. Again, the serum uric acid here around, as you'll see the levels. So it's significant, the incidence of CKD in this group of individuals. This is type 1, type 2 diabetic patient followed for 5 years. And that indicates significantly greater in type 2 diabetic patient with hyperuricemia than without hyperuricemia. Now, what about the disorder that we see here with uric acid? Crystal-induced disorder, non-crystal induced, and oxidative stress. I think I would concentrate mostly on the crystal-induced, which There are three major crystal-induced deposition disorders: gout, urate nephropathy, and nephrolithitis. And all these are really important for us. Substantial evidence support the view that persistent asymptomatic hyperuricemia imparts risk for development of urate or uric acid crystal-induced clinical disorder. These respective risks are at least in part related to magnitude and the duration. The higher the level and the longer the hyperuricemia, more likely to develop such situation. Now, what are the crystal? Gout, all of us were familiar with it. Uric acid stones, and tumor lysis with its acute urate nephropathy syndrome. Now, what about urate nephropathy? When you talk about the kidney and urate, we have the acute uric acid nephropathy, we have the chronic urate nephropathy, and we have the uromodulin kidney disease, which is a disorder of uric acid. Acute urate nephropathy, all of you are familiar with, which is a typical acute kidney injury associated with tumor lysis and other substances being released. And usually it's due to overproduction of uric acid and over-excretion. So you have high level of production and you are excreting large amount, so you smudge your renal tubules with that. Typically, it occurs with malignant cell turnover, lymphomas, leukemias, lymphoproliferative disorder, and it may occur spontaneously or usually after chemotherapy or radiation. How it happens, really, we have cell breakdown resulting in purine, metabolism, hyperuricemia. Hyperuricemia crystallization, and also some other substance, which we know that phosphate, and can induce crystal-dependent kidney injury, release of inflammatory disorder, and that vasoconstriction, autoregulation disturb, and renal blood flow decrease. All this will result in acute kidney injury in a patient with typically tumor lysis syndrome. How we diagnose that? The history. Typically, there is no symptom related to urinary tract infection, rarely urinary tract, rarely flank pain. Uric acid usually is quite high, more than 15. Other form of acute injury usually less. And if you are lucky enough, you can find some crystal like needle-shaped crystals in the urine of your patient. And one test really, we can uric acid creatinine ratio more than 1 usually is diagnostic and pathognomonic. And that's different type of uric acid. You can see it really in the urine. Clinical manifestation, usually pending, possibly leading hyperkalemia, hyperphosphatemia, hypocalcemia. Hyperphosphatemia may result in acute kidney injury at the same time. How you prevent that? This is a preventable disease, should be. Strategies to prevent that: intensive IV fluids, a use of recombinant uricase enzyme in preparation to convert urate into water-soluble allantoin, and the use of xanthine oxidase inhibitor. But what about once it happened? Well, once it happened, we have to deal with it as in a case of acute kidney injury, attempt to wash out uric acid crystals by increasing urine output, and the use of allopurinol, fluvoxostat, or rasburicase. And sodium bicarbonate here, usually we are not encouraging to use sodium bicarbonate, especially because it may precipitate really phosphate and causing some trouble with calcium phosphate. Dialysis may remove the excess of circulating urate from the patient who has persistent oliguria or anuria, and prognosis usually with complete recovery is good if we initiate treatment rapidly. What about chronic urate nephropathy? Hyperuricemia is both a cause and a consequence of CKD. It can lead to CKD, and CKD can result in hyperuricemia. Frequently associated with other metabolic syndrome features, we have it with diabetes, hypertension, and obesity, and usually it's associated with increased risk of CKD. Well, there is a nice study here, a meta-analysis. We have almost 22,000 healthy volunteers who followed prospectively for 7 years, analyzed for association between uric acid level and incident kidney disease, GFR is this. After adjustment to all things, age, antihypertensive, blood sugar, and others, what they found that slightly elevated uric acid from 7 to 8.9 as a double risk of incident kidney disease. Uric acid more than 9, triple risk of kidney disease. The risk of incident kidney disease, usually linear, It goes hand in hand. When it is 6 to 7 milligram in women, more than 7 to 8 in men, after that, usually the risk is increased. The conclusion of this study, elevated level of uric acid independently increased the risk of new onset kidney disease. What about chronic urate nephropathy? Is induced by deposition of urate crystals, usually in the medullary interstitium. Unfortunately, you have to document the presence of crystals in the biopsy. Now, it looks like what we call it, like what happened in the tophi, gout tophi in other part of the body. It can induce inflammation. It can induce IFTA and progressive kidney disease. In fact, some pathologists refer to this as these pathological findings represent a renal tophi. It looks like a granuloma. Can we really demonstrate the presence of uric acid crystals there? It's usually difficult because you need to fix your sample in alcohol, absolute alcohol, because in formalin, the uric acid crystals will dissolve. If you suspect that, you should fix it in absolute alcohol. You can demonstrate that. What are the clinical features? Like anyone really, it's non-specific. Renal functional impairment, usually in bland urine sediment, minimal proteinuria, maybe very few hematuриas, mild proteinuria, serum urate concentration often higher than expected for the degree of CKD. It's primarily seen in a patient who have interstitial gout. As I mentioned, diagnosis cannot be made on clinical ground alone in absence of kidney biopsy. Urate crystals may be seen in the renal biopsy. All these changes that we see in the kidney biopsy, not really characteristic of the urate nephropathy. It can be seen with advanced arteriosclerosis, glomerulosclerosis, that long-standing hypertension or age-related glomerulosclerosis. How it really happened? Uricemia, well, activation of the renin angiosystem here, microvascular inflammation in the kidney, impaired autoregulatory process in the kidney, interstitial macrophages and T-cell infiltration, all these, and afferent arteriolopathy. All this result in really decrease in progression of kidney disease, and in transplant patient, allograft dysfunction may happen. Treatment usually will reverse. Same thing with the heart, same thing really with the brain. Now, how we deal with this? If you see uric acid from any cause, whether decreased GFR, whether it's increased production, you have renin production, activation, you have oxidative stress, you have inflammation, you have endothelial dysfunction. All this will result later on arteriosclerosis, and it's a vicious circle that it can go on and on, progressive kidney disease. Fortunately, with the use of xanthine oxidase inhibitors, usually we can interrupt this cycle and hopefully we prevent the progression of kidney disease. What is the effect of allopurinol on progression? There's two groups of patients, 56 patients and 57 allopurinol. They are identical really, their demographic data. And the use of allopurinol, see that there's blunting of the degree of the progression. In fact, serum GFR usually improved and the serum uric acid decreased. So it has a role, and there is some improvement with the use of xanthine oxidase inhibitor. And then the third thing usually, which is something that came to me really new, uromodulin kidney disease. What's really this uromodulin kidney disease, previously known as familial juvenile hyperuricemic nephropathy, familial juvenile gouty nephropathy, and more importantly, they call it now autosomal dominant tubulointerstitial kidney disease. That's a very strong history of kidney disease and gout, characterized by hyperuricemia early in the stage of the disease, and usually progressive kidney disease. Whether the crystal is the cause or not, it's not really clear. How it happened, unfortunately, it's more and more recently about gene studies evaluation. Uromodulin kidney disease most commonly caused by a mutation in uromodulin, previously called Tam-Horse protein. It's a membrane-associated protein unique to the thick ascending lobe of Henle. Thick ascending lobe of Henle. When there is a mutation, these proteins accumulate within the cell, so will expose really the expression of the apical membrane. And we know that uromodulin is a regulatory factor for ion transport, so it's being trapped within the lumen of the loop of Henle, and they are not able to work, so that will result in hyperuricemia. That in short this. Characteristically, autosomal dominant, progressive kidney disease, and ultrasound usually normal, possibly small, with some cyst changes. How you treat this, there is nothing specific about it. It's like general treatment of patient with CKD, supportive care, management of complication that you do. And usually transplantation is the best treatment for such individuals. Those patients, they are normotensive most of the time because they are losing salt and water. And if they happen to be hypertensive, losartan, as I mentioned earlier, it's one of the best drugs really to work on such individual. Transplantation for such patient is the best because disease will not recur in the transplanted kidney, but be sure that family members should be evaluated. What about hyperuricemia in kidney transplant individuals? We know that hyperuricemia is common in kidney transplant recipients, particularly those receiving calcineurin inhibitor cyclosporin. In a nice study, really, 279 patients were reviewed, 129 patients with cyclosporin, prednisone, and 168 in azathioprine and prednisone. Look about incidence of hyperuricemia, 84% in the cyclosporin group, 30% in the imuran azathioprine group. So it seems to be unique for patients with calcineurin inhibitor, mainly cyclosporin. Gout, 7% developed in the cyclosporin group, none in the azathioprine group. Another study, prevalence and predictors, 300 patients were included in the study, mean age around 49. These are all transplant patients. Median transplant time, 6 or 7.6 years. Estimated GFR is around 51. Hyperuricemia was defined as serum uric acid more than 6.5 milligram in women and more than 7 in men, or if they are using allopurinol. What they found, prevalence of hyperuricemia was 41%, 127 patients. And hyperuricemia patients predominantly were male, older, white, lower GFR, and prevalence of hypertension when they have proteinuria. But it was more in cyclosporin versus tacrolimus. They concluded that prevalence of post-transplant hyperuricemia was high, particularly in patients with cardiovascular disease factor and lower GFR. We know that our transplant patients have a lot of comorbidities. Diabetes, hypertension, cardiovascular, CKD, all may contribute to the risk of hyperuricemia and gout. So pharmacological management of these comorbidities for the hypertension, diuretics may input that, cardiovascular, other medication, so potential for drug interaction that can compromise the safety and efficacy of what we are using for gout management. Not only that, those of anti-inflammatory drugs, corticosteroid, may prevent flare of gout, and urethral therapies for long-term, usually such medication may put your patient at risk, kidney transplant patient. Now, if there is a flare and they develop symptoms, principle of flare treatment in general population apply to our patient transplant individual. Early treatment should be, the earlier the better. That will shorten the flare. Treatment with anti-inflammatory drugs at full anti-inflammatory dosage as seen possible. Use of adjuvant therapy, icing, and immobilization. Patient receiving urate lowering therapy for long-term management of gout should not discontinue this therapy when there is a flare. They should continue take their medication. What about special consideration for our transplant patient? the kidney graft function, the cardiovascular disease, hypertension, gastrointestinal, if there is hepatic impairment, peptic ulcer disease, concomitant use of medication, diabetes, composite of the maintenance immune suppression, whether they are myclophenolate, Prograf, cyclosporin, and others, drug allergy. Again, any patient who will come with single joint inflammation, always our patients are immune compromised, should be attention to joint infection, septic arthritis should be really considered before really start moving around and figuring with their management. There is no single best management agent for our patient. This particular important organ transplant, individual, you have to look about your individual patient, the gouty history, if there is anything there, and the therapies that's available. We have several classes of anti-inflammatory medication that can be used effectively, systemic steroid and intra-articular steroids. Oral non-steroidal, of course, we don't use it in our patient. Oral colchicine, and then interleukin drugs, anacarina, and beta agonist. What about colchicine? Here we have to remember low dose colchicine in patients who cannot tolerate glucocorticoids or combination, low dose colchicine should be used. Treat with low oral colchicine within 24 hours of symptoms. An effective response of colchicine is less likely if we're delaying the management. Colchicine, we have to remember not to be given to kidney transplant recipient with the following conditions. Concomitant use of cyclosporin or other medications strongly inhibit cyclosome P450. Severe kidney impairment, moderate severe hepatic impairment, concomitant hepatic and kidney disorder. Transplant patients who are receiving tacrolimus, you can dose them without difficulty in normal individuals. And then we move on now. After all this, what about the urate lowering medication that we are supposed to use? We have plenty of them: xanthine oxidase inhibitor, uricosuric agent, and uricase enzyme. And that's here, I put for you the list. We can have the metabolism of purines, xanthine oxidase, hypoxanthine to xanthine will block that. And again, xanthine to, we have two drugs, allopurinol and febuxostat. And we have the urate excretion in the urine, uricosuric, we have propanacid, sulfaparazone, benzopyramarone, losartan, fenofibrate, and this drug. And then thirdly, we have urate oxidase, uricase, that usually uricase that we have here in our country, converting this into. So there are three mechanisms, really. Decrease the production of uric acid, enhance loss of uric acid from the body by uricosic agent, and try to convert it to a more soluble drug. Now, what about recommendation, really, how we treat such patients? We initiate urate lowering therapy is not recommended in patients with asymptomatic hyperuricemia, because in one study they have 24 patients should be treated with urate lowering for 3 years to prevent single incident one gout. It's not really worth it. Initiating urate lowering agent is not recommended in patients with gout experiencing first flare. But if they have kidney disease like our patient, yes, you can. If they have high serum uric acid, yes, and they have stone disease. So with the first flare in our patient, I think we should start urate lowering therapy. Asymptomatic hyperuricemia is not an indication to treat in kidney transplantation. In fact, this will be a golden chance for us to see what's going on, can assist the patient for their progression of their disease. Issues should be considered during this time: the need for pharmacological urate lowering therapy, pharmacological management associated comorbid condition, and try to manage their medication if we can change their medication or not. Now, in practice, what's the target uric acid level or urate? Most widely recommended goal of range of urate lowering therapy is around 6, with substantially below the urate solubility, which is 6.8. Some people, they advocate less than 5 in patients who have to 5. Maintenance of subsaturating level impedes the nucleation for stone formation. Your target, as I mentioned, this is the recommendation to 20 American College of Rheumatology. Usually it's around 6 or less. And here we have plenty of recommendation, 2016, 17, 19, Japanese, American, and others. But mostly there is one study here, they mention less than 5. And again, lower than 5 usually facilitate faster dissolution of crystals. Now, you have to keep uric acid low. The longer you keep uric acid low, the less frequently your patient will develop diseases. Now, what's the difference really between the two xanthine oxidase inhibitors? We have here allopurinol and we have febuxostat. In the green, you have the allopurinol. It is non-selective. It will inhibit early parts of the purine cycle metabolism and xanthine oxidases. While the febuxostat, it's selective only for xanthine, for this process hypoxanthine enzyme. Indication, kidney transplant patient, urate lowering therapy should be initiated at low dose. Remember, start low dose. And we should administer with it an anti-inflammatory agent when feasible to avoid the risk of activation. Because we have a good number of patients, when you give them urate lowering therapy, they will come to you within a week time with flare of gout. So such individuals may be given anti-inflammatory agent, mainly colchicine in our patient. First line of therapy, allopurinol preferred, the xanthine oxidase, because the cost of febuxostat it's high, and concern about cardiovascular disorder, that particularly cardiovascular death with febuxostat initially. Again, allopurinol is preferred over uricosuric agent because easy to use, and usually such uricosuric agent, their effectiveness is reduced with advanced renal functional impairment. Now, you have to remember, both allopurinol and febuxostat should be avoided in patients treated with azathioprine, because we know that azathioprine, the active metabolite of it is 6-mercaptopurine. The conversion of 6-mercaptopurine to thioric acid reaction that catalyzed by zinc oxidase. Both allopurinol and febuxostat block this reaction, resulting in accumulation of 6-thiourea acid, and that will result in disastrous bone marrow suppression. So please, no use. If you have no choice, you should reduce the dose of azathioprine to 1/3 with close monitoring of your patient. This is how we start with GFR of 60, GFR of 30. Always start with lower dose, and then you try to upgrade usually your dosage according to reach target level of 6 milligrams. No need to reduce the dose of, you need to reduce the dose of allopurinol in renal failure. Reduced dosage means efficiency decreased. Risk of toxicity can occur. Now, what's toxicity really? We know that in our body, allopurinol is oxidized into oxypurinol, metabolite oxypurinol. And both oxypurinol and allopurinol, they block xanthine oxidase. Okay, but unfortunately, in patients with renal disease, this is usually the metabolites of excreted in the kidney. And when there is a renal disease, see what will happen. Oxypurinol will accumulate with all its potential complication, allopurinol toxicity syndrome, hypersensitivity syndrome, toxic epidermal necrolysis, Stevens-Johnson syndrome. All these will occur in a patient with impaired kidney function. So you have to be quite careful. So if we don't have that, then we have the febuxostat, which is again xanthine oxidase inhibitor. And xanthine is quite effective in reducing hyperuricemia in renal patient and non-renal patient, transplant patient and non-transplant patient. What's the difference really between the two compounds? Well, febuxostat is selective, while that is non-selective. This is non-purine based, this is purine based. And usually inhibit both oxidized and reduced form, that's only reduced form. excreted mainly in the urine, and feces that excreted mainly in the urine. So that, as you notice, there is some potential complication in patients with renal disorder. Nowadays, by the way, we are using good number of our patients that are using febuxostat. And it works, as I mentioned here, it's non-selective. Start with small dose, like the other medication, 40 milligram, and then you titrate your dosage accordingly. Target will be in the range of 6 milligram. Febuxostat dose reduction in kidney function not required unless you have your GFR basically less than 30 ml per minute. In this group of patients, always please 40 milligram, not more. And it's effective, really. Confirmed study, look how efficient. Stage 2 CKD, stage 3 CKD. That's a good number of patients. In the blue, allopurinol. Here, the orange, febuxostat, usually 40 milligram. And here, look about the group of patients who really at the last visit, they maintained 6 milligram. Almost 71% of the patients with either stages of kidney disease, they maintained this. Advantage in patients with advanced kidney disease, yes, febuxostat is safe compared in other urate lowering drugs. Febuxostat is primarily metabolized by the liver and it's highly selective, not uricosuric. Again, so not going to cause any stone disease. Effect of febuxostat in renal function with chronic kidney disease. As you'll see, really good number prospective. It's renoprotective, no significant difference in complication and death. Now, a lot of things happened. And if we see here that reduction of 1 milligram per deciliter uric acid with febuxostat result in 1.1 ml reduction in slowing of GFR, preserving GFR. The red, no treatment, the blue, treatment of febuxostat, and that's the whole group of patients. No dose adjustment is necessary unless you have advanced renal disease. Efficacy usually is good. In liver, you have to remember that it's metabolized in the liver. Hepatic impairment, you should be limited use. Other side effect, we know that all can happen, but more importantly, that a lot of things initially came in about myocardial injury, unstable angina, and should be avoided in patients with that. Now, initial concern was really greater cardiovascular death. It happened with febuxostat with the CARE study. And then we have the FAST study basically came in with result. You have really not inferior and no more side effect of that. This is a large number of patients that are being treated, almost 6,000, and all the way febuxostat and the allopurinol. The primary composite endpoint was hospitalization, non-fatal myocardial infarction, and markers for acute kidney injury. As you'll see, blue is the febuxostat here, and red is the allopurinol. So there is a good difference, and really here febuxostat was not inferior than allopurinol for incident of primary end result. Same thing, all-cause mortality, it was less, and cardiovascular death again was less. So basically, now we are using it with more liver. Our cardiologists no longer really are worried about. So the conclusion of this first study that febuxostat is non-inferior to allopurinol therapy with respect to primary cardiovascular and long-term use not associated with cardiovascular death and serious complication. Third line of therapy, which is the uricosuric agent, in combination, you can use it patients who are really not reaching target with the other medication, then you can add uricosuric agent. What are the uricosuric agent we have? We have benzopyrrolone and propanicid, and all of them really, they have their effect and their side effect with that. But you have to remember, patients with azathioprine were treated with this, so they have a less chance of developing allopurinol toxicity. I'm not going to go through this. I'd like to anti-inflammatory use in transplant patient. When there is a flare, the only thing really, colchicine, glucocorticoids, please don't use non-steroidal. And I'd like to conclude, Mr. Chairman, by this couple of slides. Is uric acid friend or foe for us? Well, depends how you look at it. And here, is it good, the bad, and the ugly part of the uric acid that we have? Some benefits, and to 5, which is the bad and the ugly, when they have stroke, when you have myocardial infarction and kidney disease. And I'd like to stop here and thank you for your attention.
Thank you very much, Professor Riyad. Thank you.
It's 11 o'clock.
Thank you, Professor Riyad.
Naam.
Yes.
Thank you, Professor Riyad, for your highly comprehensive and very, very nice and interesting talk for this very hot topic. Please, Professor May, you can start the discussion and can expect a very hot discussion due to a lot of professors present with us today. Please, Professor May, start.
Thank you very much, Professor Riyad, for a very elegant and informative and inclusive presentation. So let me ask you, would you give your CKD patients, all those with the serum uric acid more than 6, would you give them treatment to reduce the uric acid?
Asymptomatic, unless they reach around 8. Usually my threshold will be around 8.
So if it's above 8, you give them?
Yes, around 8, yes, I will start.
The thing is that, yes, it is, uric acid is a risk factor for progression of CKD. But the thing is that they say that being at the scene of the crime does not mean that you are the criminal. So we have to have studies, I mean, big studies, to show that treatment of uric acid really did decrease the progression of CKD. And I think you mentioned some of those, because in the past there were only small studies and short-term studies. So do we really have that kind of studies that can make us go ahead and start treating all our patients with the uric acid more than 8?
Well, I don't think that really, very few that I mentioned, but really in the past used to say, well, this is the kidney is the cause of being high uric acid because under excretion. But more and more, really, we start seeing complication of that. Unfortunately, you have to look about kidney disease is not really isolated from other components. What we have, they are hypertensive. We are using diuretics. They are cardiovascular disorder. There are a lot of comorbidities that usually present with them. So which come first? So we really now err on the possibly the improvement aspect of kidney disease by treating them, trying to keep their uric acid around 6, not really less than that, with a minimal dose of basically the urate lowering agent. That's really what I do. I don't know what about my colleagues, the other audience.
Anybody would like to comment on that?
Professor Hani Hafiz was us.
Yes, I see Hani there.
اهلا وسهلا يا دكتور رياض حضرتك يعني منور.
خليك.
I have الحقيقه يعني a couple of questions. الجروب الاولاني من الاسئله regarding للتو ستاديز اللي اتنشروا في النيو انجلاند جورنال اوف ميديسن، البيرل ستادي بتاعت اليونايتد ستيتس والسي كي دي فيكس ستادي بتاعت استراليا. الاثنين الحقيقه لما ادوا للبيشنتس قالوا بيرينول بالذات في اليونايتد ستيتس for 3 years, they did not got an improvement in the progression of CKD. ورغم ان الاستاديز الاولى بتاعت ريتشارد جونسون كان بتقول ان في some improvement حوالي 4 مللي per minute per square meter. الاثنين ستاديز دول did not prove that. فيمكن ده بيرجعنا تاني للسؤال بتاع الدكتوره مي ان ما زال في كونتروفيرسي كبير.
yes.
ندي ولا ما نديش. فده اول كومنت كنت عايز حضرتك يعني تعلق على البيرل والايه والسي تي دي فيكس ستادي. الحاجه الثانيه بالنسبه للليفنج دونرز. الليفنج دونرز في increase incidence of hyperuricemia في الليفنج دونرز. فهل ده يعني يخلينا يعني الميكانيزم بتاعه ايه؟ لان انا برضو يعني لقيته كستاتستكس لكن ما فهمتش ليه الليفنج دونرز هيبقى عندهم هاير ريسك اوف هايبريوريسيميا. وبعض زمايلنا الحقيقه بيعملوا حاجه قبل الترانسبلانتيشن بيدوا للدونر الوبرينول از ان هو الكدني لما هتتشال وتتحط في الريسيبيانت ده ممكن يقلل الانستنس اوف اي تي ان. فهل في اي داتا على هذا الموضوع ولا ده كلام؟
No, this is really something new to me, but the explanation that post donation hyperuricemia, it can basically because they lost part of their GFR. We know that their GFR is decreased. So the capacity of excretion, they are under excretor for the time being. You know, he started with GFR, let's say 90. We took one kidney out. His GFR dropped to 45. It takes time really to get up hypertrophy and to accommodate for that loss. So that's why hyperuricemia may be seen in post-donation. But to give the donor a drug in anticipation that the kidney will be taken out of him to be given to the recipient to prevent ATN, it's really, to me, something new. I don't know what.
بالنسبه للبيرل والسي كي دي فيكس راي حضرتك فيهم ايه؟ اللي هم اللي ما لقوش ان في تحسن باعطاء الالوبرينول.
Well, it's one of the major studies, yes. But Richard Johnson, you referred to, from Denver, Colorado, they have, and I showed a couple of slides really from the Jalal, you know, the one of our, in fact, resident. She to be, you know, with us, and now she's with him there, and she's the one who wrote this article. They are using it, and it seems to be it's working. So it's really still, it's like, you know, we are shifting 180 degrees, like the pendulum is swinging. So err on the safety. Now we have safer drugs, less chances of complication. Follow your patient closely. You may achieve something. We are, again, if we can manage and save really 10 ml per minute every 3 years, well, that's fantastic.
Yes.
Of our GFR.
Thank you very much.
Ali.
Professor May, we have many comments.
Yes, let's take questions on the floor.
Professor Ali Taha, please. Unmute yourself.
Excuse me?
Professor Ali Taha, please.
Please unmute yourself, Professor Ali Taha. You're muted, Professor Ali.
Okay.
Yes.
That's it, yeah. Professor Riyad, excellent talk. The same question of Dr. Hanan to my, the level of uric acid, how about 8 milligram? And there is a CKD occurs rather than possibility of hyperuricemia. See, the patient is diabetic, hypertensive, and create 2.5 or like this, and uric acid per chance is 8. How about how to differentiate CKD uropathy or nephropathy due to hyperuricemia? We give the anti-hyperuricemic agent or not?
Well, it's very difficult. Usually because the clinical presentation most of the time is the same. There is no clinical symptom unique for hyperuricemic nephropathy, okay, because of the so many comorbid conditions that you alluded to. Your patient is hypertensive, he's on many drugs that will increase the uric acid. Your patient is on heart failure, you know, medication, diuretics right and left. Your patient is diabetic, hyperlipidemic. So really all these compounding factors interact together. They will lead to hyperuricemia. As I mentioned, the only way is to have a kidney biopsy. And again, the kidney biopsy findings is going to be more or less the same like others. Glomerulosclerosis, interstitial fibrosis, the only way if you can document uric acid crystals in the biopsy, which is sometimes most of our labs, they don't really look for it. So I'll treat if that's the case.
Yes, okay, thank you.
Welcome.
Professor Hisham?
I see him laughing, Dr. Hisham.
Thank you very much. We always learn it from your side, Professor Riyad. And you really touched the hot point of clearing the smoke of to give or not to give. For my opinion, whatever the results of the randomized controlled trial, I always believe that I will be happy to normalize everything, because we don't know, and exactly we cannot individualize whose patient will have hurt from high uric acid from not. So my opinion is to normalize everything. And I understand we will live in this debate for more years, because we cannot differentiate which patient at more risk of higher asymptomatic uric acid. For example, hemodialysis patients, they never got to my side gouty uropathy if they developed hemodialysis, because it's for sure small molecule and dialysis. So I think almost all professors and colleagues and doctors will fall in this debate for decades, and it's ongoing debate. From my side, I think you may agree with me, and I was very happy seeing your fantastic slides to give treatment of hyperuricemia. So I think no sharp answer for giving or not to give, but my heart feeling always is to normalize everything.
I agree.
Excuse me, Professor Professor Riyad.
No.
Professor Hisham, but we are to remember that, Professor Hisham, we are to remember that side effects of the drug, and especially in the case of this hyperuricemia, the harmful side effects, very harmful side effects of the anti-hyperuricemic drugs. So
Well,
I think normalization as a rule usually should
yes,
be considered.
you may have side effects
from
every drug. You may have side effects, but if you have, it's normally finding that if you have a side effects of any drug, you have to stop, even if it's a vitamin.
Well,
so I understand that.
Let me comment on this. Again, you may really worsen your kidney function by giving such medication. We know that the drug allergy, usually sensitization, interstitial nephritis, granulomatous interstitial nephritis can occur.
Exactly.
So really, it is usually you have to weigh the benefit versus the risks. That's one thing. And you have to follow your patient closely. You may have creatinine 2.5, you give allopurinol or febuxostat, and then within a week time, 6 or 10 days, your patient will come with worsening of kidney function. Here you are, there is some trouble. But this is really the rule. I'll try really to err on safety, so long I can manage the patient and I can follow the patient closely. And that's really my message.
Yes, it's exactly. You have to follow up the patients after starting of any drug, ACE, ARBs, hyperuricemia, antihypertensives, anything. We have to follow up shortly after starting any medication.
Well, that makes me remind me of now what's really the debate more and more now, whether with the ACE and ARBs. Now, whether to stop if there is worsening kidney function or really to continue. Because now the pendulum is swinging. Now more studies now are telling you, yes, you should continue the use of your ARBs or ACE for your patient, even if their kidney function is really quite. Before, we used to say, well, less than 30 ml per minute, please stop, or if there is minimal rise. Now you can continue even to the point when they reach dialysis. So really, you have to look about the benefit of the drug in different aspects. Okay, the kidney, yes, it's our major concern, but to look about it may help hypertension, it may help in cardiovascular protection, stroke. So it's really summation of the effect of medication that all we should take it together, not really be a tunnel vision concerning one category of diseases.
Okay, we have many questions on the chat. We can start. Professor Riyad, Professor Dr. Masoud Khairi asking 2 questions about the duration of giving urate lowering drugs and what's the dose of colchicine in patient in hemodialysis and FMF?
It's okay. Now, urate lowering agent, always you should keep it to target unless you have to reach 6 milligram. You can keep it for a long period of time. That's basically the treatment. Now, the colchicine, you have to remember in patients with advanced kidney disease, dialysis patient, you have to be quite careful about it. It may cause really some trouble with you. So basically 0.5 milligram, maybe every other day, it can really work for us. For patients with familial Mediterranean fever, per se, if you have an acute episode of familial Mediterranean fever, flare up, what I'll do really, I'll have 2 tablets. We have 1 milligram tablets here with us. We divide them into 2. We have 4 fourths, 4 halves. Every hour on the hour, I'll give him half milligram. By the 4th dose, 2 things will happen, either diarrhea or he's completely asymptomatic. Next morning, I will give him 1 milligram. We'll continue on that. That's for familial Mediterranean fever flare that we have. But in dialysis patient, you have to be quite careful really with the use of colchicine because of its effect that you're going to see it, side effect. Any comment from our group?
Yes, any comment? We have...
Dr. Hani agree about this, or you have...
Dr. Faisal?
Dr.
Yes, I think...
agree مع حضرتك طبعا.
From my side, I always...
Excellent talk as usual, Prof. Riyad.
Ahlan Faisal.
Ahlan bik. I wonder, you didn't mention maybe, or I missed about leukopenia, which was especially with azathioprine plus
oh yes, I mentioned that.
You mentioned.
Oh yes, that's it's
we have to pay attention to this about leukopenia. Sometimes we hold our breath if we start allopurinol and the patient is taking azathioprine.
No, I mentioned that because 6-mercaptopurine metabolism usually accumulates, and that's very toxic level to the bone marrow, and you're going to see real disasters, bone marrow suppression, and leukopenia from that. Yes.
And you always start with febuxostat, Professor Riyad?
Well,
rather than
currently, yes, it is really so effective. In fact, I'll say the practice now used to be before several years, 100% allopurinol. Nowadays, I'll say basically 2 to 8. From 10 patients, I may have 8 patients on febuxostat and 2 patients on allopurinol.
If you allow me, Professor,
it really works very good, very effective.
If you allow me, Professor Riyad, there is very important point, just to touch it now. If the patient is FMF and on dialysis, what about the cardiac risk from amyloidosis and the other deposition? So if the patient is already on dialysis from the kidney disease, from amyloid, FMF disease, I think you may agree or not that continuing on small dose of colchicine may be value.
Yes, yes. In fact, if we transplant them, again, if such patient will be transplanted, one of our protocol, one of the drugs is colchicine, is part of our immune suppressive therapy that we use for them. Yes.
And the heart as well, protection for the heart from amyloidosis and restrictive cardiomyopathy?
I don't know.
Yes.
It seemed to be of value. You always make the patient with dialysis, FMF, to continue on a small dose of colchicine for protection of other organs.
Yes, yes. It was mentioned every other day.
Yes.
Yes, exactly.
Yes, we usually maintain on minimal dose, even not on dialysis. We have a case scenario on the chat, Professor May. Yes. And Professor Riyad, if you can look on the chat with this case scenario, because it has many informations and may be difficult to deliver it.
How we can see it.
49. Okay. Yes. 49-year-old lady, diffuse psoriasis, only have ketonuria and non-diabetic with hyperuricemia. So psoriasis, diffuse psoriasis, and ketonuria. Uric acid is 14.5. Normal CPC and normal potassium, normal calcium, normal renal function test.
We know that psoriasis By the way, psoriasis is one of the causes that I mentioned in my slide, that it can cause increased uric acid production, a lot of cell turnover.
Yes.
Okay, so it's one of the etiologies of hyperuricemia. So treatment of psoriasis if possible, and then you should really treat the uric acid. This is a very high uric acid. Even if you have normal kidney function, this is a very high uric acid, should be treated in conjunction initially with anti-inflammatory medication, possibly colchicine. You may use non-steroidal with that if they have normal kidney function.
Yes.
Okay. Thank you. Another question from our coordinator today, Professor Islam, and it is a good Dr. Islam. This is a good chance to thank him, Dr. Islam Abu Ni'ma, for his activity and for his coordinating this meeting. He is asking about the level of uric acid. Shall we give the difference according to the difference of, is there a difference, the meaning of the question, difference in GFR about regarding the target level of uric acid by treatment, or there is a unique target for all differences?
All degrees of GFR, your target is the same. Okay, yes. Your target is going to be 6 milligrams because the solubility of urate in our body is around 6.8 milligrams. So you try to keep it really less than the theoretical solubility of urate in our body. That's the target. Now, how much dose, how you can grade the dosages depends upon your GFR. GFR less than 30, you start with 40, maybe every other day. Okay, GFR between 60 and above, you start with 40, and then within 2 to 4 weeks, you can really go up to 80 milligrams. In fact, some studies, they went up to 120. In fact, we remember that the boxistat, which is adenuric, is being 80 milligrams and 120 milligrams, not really 40 and 80. So there are studies going high up to that level. But all your GFR degrees, your target is basically the same, 6 milligrams per deciliter.
Could I tell you what I do, Professor? I'd like to know your opinion on that.
Yes,
so for CKD patients, I don't really treat levels of 6 or 7. I only treat when it's approaching 10, like 8 and 9. And 10.
I mentioned I treat, Dr. May, if they are around 8. If they are above 8, so, I will. And then I try to maintain it down to 6.
Yes, exactly. Okay. So to start, it doesn't have to be, it has to be a little bit high near 10 to start and expose the patient to the side effects, etc. But then the target will always be 6.
Yes.
Yes.
You know, so your starting point is different. It all really mentioned that around 8 and above, then you really start using. Some people 9, some people 10, and that's usually, I'll start around 8, but my target is 6.
Okay. Professor Saied Khamis wants to comment.
Good evening, Professor Yasser. Thank you so much. Thank you, Professor
أهلا يا سعيد. أهلا دكتور خميس. أهلا.
ازي حضرتك يا فندم؟ الله يخليك.
الحمد لله.
محاضرة رائعة كالعادة. Thank you for this elegant presentation as usual. Just my question regarding the raspy uricase. I think in the patient with favism or glucose 6-phosphate dehydrogenase deficiency, it is an absolute contraindication. So we should.
That's true. You should test your patient to start with for G6PD. Yes.
Yeah, it's mandatory, I think. Second issue is other side of the coin is hyperuricemia, and hyperuricemia is another issue. And always we forget this issue, actually. It can lead to also renal stones, and also it can be associated with Fanconi syndrome or Wilson or other diseases in the kidney. So hyperuricemia is also an important issue we should focus on, like hyperuricemia. What do you think, sir?
Well, in fact, I'm supposed to put one slide, and I have it really here. Hyperuricemia, again, it's usually due to, mostly you can see it in acute Fanconi syndrome and others, but also you can see it with certain gene difficulties. And we know that usually when there is urate transport in the proximal tubule, there is something, loss of function or genetic high probability of wasting urate in the kidney. Yes, with exercise, with others, you may develop acute kidney injury.
Yeah. Because it's two types. type 1 this is due to excessive excretion, and the type 2 is due to decreased senses. And this increased excretion, this is a genetic type, as you said, and it can lead to what's called marathon-induced AKI or exercise-induced AKI. Yeah. Okay, thank you.
Okay.
Thank you. A question from Dr. Samar Ahmed. Any precautions for respiratory dose in renal impairment?
The only thing you have to remember, G6PD deficiency with hemolytic anemia can occur. That you have to test your patient for it. And usually it's been basically reserved for very extreme high uric acid, usually with urate tumor lysis syndrome. When you have we have uric acid sometimes 20, 25, then combination uracase and dialysis, all that will work together. But please, you have to be aware of this, as Dr. Khamis mentioned, for the G6PD deficiency.
Another question about the early urate. Can early urate lowering therapy slow down the progression of autosomal dominant tubular interstitial kidney disease?
This is what we call the uromodulin nephropathy, autosomal dominant tubulointerstitial kidney disease. Yes, because this usually starts as this is disease that occur at young ages, very high uric acid early, and then progressive kidney disease. Yes, it should be part of your therapy. If you diagnose that as the autosomal dominant tubulointerstitial kidney disease, which is uromodulin type 1, or we have so many types, then yes, the earlier, the better will be. This is mostly pediatric condition. I don't think that really we do see it ourselves as an adult. This is something new to me when I start reading about this condition, the hyperuricemia.
Dr. Khalid Abu Zaid wants to comment. Please unmute yourself. Unmute yourself, please.
Assalamu alaikum.
Alaikum salam.
Excellent presentation as usual. My case scenario is the one in the chat. It was my patient have ketonuria and metabolic acidosis.
Ketonuria, yes.
My question actually, why this patient have this metabolic acidosis and the ketonuria, and the patient non-diabetic, non-alcoholic, not fasting? There is any clear reason that the patient has this metabolic, non-anion gap metabolic acidosis with ketonuria in a patient with diffuse psoriasis and hyperuricemia? I already have explanation for hyperuricemia because of psoriasis, but actually I didn't have explanation why the patient has this associated metabolic acidosis and the ketonuria with this hyperuricemia. I can have explanation for Fanconi syndrome in relation to interstitial nephritis and something of this hyperuricemia effect. But with hyperuricemia, is it explained? Is this non-anion gap metabolic acidosis and the ketonuria in a case like that?
Well, non-anion gap, we know that type 4 renal tubular acidosis can occur.
But potassium is normal. Potassium is normal.
Because we know that type 4 renal tubular can occur with this chronic tubulointerstitial disease that can really part of the disease. Now, we know that in diabetic ketoacidosis or just ketonuria or lactic acidosis, all these things, these are organic substances. They will compete through the transport mechanism with uric acid. And that's why the uric acid will go up. But why really your patient develop non-anion gap or anion gap metabolic acidosis, I can't answer that really. But definitely with ketonuria, fasting, starvation, usually you can see hyperuricemia based on the accumulation of these ketone bodies.
Second question, please. Why some patients have hyperuricemia for long period, resistant and refractory to the medication and the other forms of lifestyle, but they didn't have any incident of gouty arthritis or gouty attack? Well, why some patients have normal uric acid and have gouty attack, and some patients have hyperuricemia without any gouty attacks?
Well, one third 1/3 of patients with asymptomatic disease usually develop symptoms, asymptomatic, and 2/3 will continue really without any symptoms. So it's very difficult to tell who's going really to develop this flare up or develop crystal-induced situation. Okay, that's one thing. The second thing about what's the part of your question? The second one?
Some hyperuricemic, some normal uric acid level patients presented with hyperuricemia side effects, gouty attacks, and sometimes to fight, and sometimes to fissures. And the cardiovascular risk. And
now we do see this, in fact, with patients when you have uric acid in the range of 7 or 8 or 10, we put them on urate lowering therapy, and then suddenly your uric acid will come down to 5, they will flare. Okay, the sudden flux and change in the serum uric acid with possible precipitation in the tissues, and especially if you are using uricosuric agent, it may really cause flare. But other than that, really, I don't know. I don't know. Any one of my colleagues, I'm ready to, Dr. Hisham, he's laughing always. What do you think?
I always laugh with your seeing you, my professor.
Allah yakhallik.
It's very excellent question from Professor Khalid Abu Zaid, our colleague and ambassador in Saudi Arabia. Actually, yes, your question is touching out point, and I will give one example of that. In dialysis patient, beta-2 microglobulin is almost always high in all patients, either low flux or high flux. But 25% only on low flux group who developed carpal tunnel syndrome and other deposition. So there is a difference between chemical number of the lab testing like hyperuricemia or increase in beta-2 microglobulin. It is the chemical found number and the deposition of the joint like beta-2 microglobulin and synovial like uric acid. Additional factor is important. For example, in dialysis is inflammation. If you have a high value of cytokines or glycated proteins, you have changing the character of molecule of beta-2 microglobulin, so it attacks the synovium and deposition. In hyperuricemia, not only the inflammatory cascade, as well the stressful factor. So if you have a tight shoes, if you have, for example, very stress on knees, it is deposited in the joint. So hyperuricemia is a chemical increase in uric acid, but gout need additional factor to be deposited.
Professor Muhammad Hani Hafiz, Professor Hani Hafiz wants to comment.
لا هو الكومنت بتاع الدكتور هشام كافي، يعني واضح ان الليفل نفسه يعني ممكن يبقى كيميكالي هاي لكن مش not clinically reflected يعني.
Okay. Could it be related to the genetic background as well? No. Maybe it's genetically determined?
It's very difficult really to tell. But
I have a question.
It's noticed there, yes.
I have a question. Let me ask a question, Professor Riyad. You mentioned that in transplantation, some of the usual practice is to give an anti-inflammatory in addition to urate-lowering therapy, fearing of the start of the gouty attack during flare during intake. Is it the same practice in usual CKD as many of my colleagues, rheumatologist colleagues do this, are usually afraid of the flare with initiation of urate-lowering therapy with normal GFR. Is this the common practice with CKD or only in transplantation?
CKD also. CKD.
CKD or
yes.
CKD. So you recommend that to initiate an anti-inflammatory in addition to
there is no need to provoke them and make them really, if they have no just asymptomatic and the level is around 9, as Dr. May mentioned, we give them treatment, they will come a week later really with flare. So what I'll do, my practice really, what I'll do, I'll give them colchicine, for example, if they have moderate renal function and impaired mild to moderate, maybe 1 milligram every day or every other day, depends, for a week time. And then I'll initiate the urate lowering therapy next week. They will continue the second week really of both colchicine and usually the lowering agent. Third week, I can stop. If I'm worried about colchicine side effect, third week, I'll stop the colchicine, continue the urate lowering therapy. So that's really what I do in my practice. And that really worked well. And by this, you try to prevent the patient who comes to you. Well, you give him, your uric acid is high. Let's give you this drug. A week later, he will come, he's limping to your office, something that you don't like to see.
Yes, something.
It's painful. It's really painful. You know, gouty arthropathy, acute gout flare is really painful.
And usually not on the side of the doctor to initiate a flare in a gouty patient. No one wants the flare. So yeah. How the dose of colchicine do you use with the anti-inflammatory, with the urate lowering therapy? Colchicine, how many milligrams?
I use 1 milligram. That way, some places they have half milligram tablets. I think in Egypt you have half milligram.
Yeah.
Here, what we have is 1 milligram tablet. We can give it 1 milligram daily for that week. If decent kidney function, if there is abnormal kidney function, half milligram, we can go with that. And the first week, and then second week, you initiate urate lowering therapy in conjunction with the colchicine. Third week, you stop the colchicine, you continue with the urate lowering therapy. So there is an overlap for 1 week together.
Okay, my question, second question is about the anti-inflammatory in transplantation. You said steroids, and the patient is usually on steroids.
You may up the dose. You may up the dose of steroid, because I'm sure you're not going to give Voltaren. You are not going to give the other medication, ibuprofen and others. So we try to, you know, you can up the dose of steroid therapy shortly. Yes.
Double the dose, for example, or recommend more?
No, if the patient, most of them chronically, they are on 5 milligram. And some people, they are really, if they are on steroid sparing transplantation protocol, they are off prednisone. So 10, 20 milligram, that really will be more than enough.
Okay, thank you. Professor Meyer, any comment? We have no more questions and more chats.
I'd like to ask about the use of losartan and SGLT2 inhibitors for the sake of lowering uric acid.
Losartan, yes. Losartan, I mentioned losartan. Yes, it is only one of the ARBs usually will lower uric acid because it works on prevent its tubular reabsorption. So you can use it. SGLT2 inhibitors, something new. I don't think that really I found any data about that. But we have a good number of patients with SGLT2 inhibitor. It's time really to start looking about their uric acid as, you know, benefit of what we are doing. If there is lowering of uric acid or not, it may work. I'm not sure. Do you have any experience?
I mean, because they both work on the transport proteins, the urate transport and the GLUT9, so they both work on those transport proteins. And it has been shown that SGLT2 also lower the uric acid, maybe through this mechanism. So I'm just suggesting that they could be used for that as well.
As side benefit, you know, it may be to start with, yes. But I don't think that really I will give it strictly as we are giving it now for proteinuria, for example, for kidney disease. Later on, you may, you know, you need to accumulate more data about this before you really legitimize just giving SGLT inhibitor for treatment of hyperuricemia. That's off, you know, outside the box.
Dr. Riyad, I wanted to comment that losartan is the molecule itself not being an ARB, yes, because candesartan, for example, is known to increase the uric acid level.
That's true.
So it seems that the molecule itself of losartan has something different than the other ARBs.
That's exactly why it's the only drug. If you have a patient hypertensive, high uric acid, you can use losartan.
Yes.
Last question on the chat from Dr. Samar Ahmed asking if there is a difference in urate in the dose of colchicine if there is a flare on urate lowering therapy in peritoneal dialysis patient than the patient we mentioned. There is difference regarding peritoneal dialysis regarding hemodialysis.
The dose of colchicine, yes, in peritoneal dialysis patient?
Yes.
I don't think that really there is a difference. It's going to be more or less, it's a small molecular substance, can be cleared really, you know, with the hemo or peritoneal. And we have Dr. Hisham Saied, he's the expert on dialysis.
Okay.
Thank you very much, Professor. You are our mentor, yeah. So your answer is absolutely correct.
Okay, thank you.
No more comments and no more questions on the chat. And do you see to close?
Yes, thank you very much, Professor Riyad. It was really very interesting, and we really needed to learn and to know the views of others as well, and about how they're dealing with this rather still controversial issue. So thank you very much, Professor Riyad, and thank you all for attending. And I hope we see you next time, inshallah. And we also hope to see you soon in our conference. Yes, inshallah.
إن شاء الله. شكرا جزيلا دكتورة مي، شكرا جزيلا دكتور ياسر، زملاء دكتور هاشم، دكتور هاني, and the audience. I really enjoyed your comments and the discussion, and looking for more future interaction between us and your society. Thank you very much.
Thank you very much.
Thank you, Professor Riyad. Thank you, Professor May.
Thank
for
you.
this highly interesting session, and very interesting session, and as expected, very interesting discussion. And thank you for your response for all of the aspects of discussion in very smart, nice, informative, and comprehensive way. Thank you all our professors attendant, Professor Hani Hafiz, Professor Hisham Saied, Professor Saied Khamis, Professor Faisal Shaheen, for their interaction with us, Professor Ali Taha. Thank you for this very interesting session. See you and meet you next Wednesday, inshallah, in our journal club, Kidney Journals Updates by Dr. Professor Ahmed Abdul Wahab. And next Wednesday, inshallah, our same time, 9 p.m. Cairo time. See you. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله.
Thank you.
ألف سلامة. مع السلامة.